Kia ora, and welcome to this short presentation. We're talking about autonomic dysreflexia, and the main point I want you to know about autonomic dysreflexia is that it can be a medical emergency and that it's likely to occur in anyone who's had a spinal cord transection at the level of T6 or higher. But of course, in true academic fashion, the first thing I have to do is to convince you that there's an issue first. There's approximately 35,000 people in Aotearoa that live with spinal cord injuries, and it's likely there's going to be 200 new spinal cord injuries occurring over the next 12 months. For those who have suffered a complete transection of their spinal cord at T6 or higher, there's a 90% probability that they're going to be susceptible to this autonomic dysreflexia. The actual incidence of its occurrence is not as well known, but the risk of an episode might fall anywhere between 20 and 70% in a susceptible person, or in other words, between 1/5 and 2/3 of people with a T6 lesion are likely to have a symptomatic episode associated with the autonomic dysreflexia. And to make matters worse for a few, this can happen up to 40 times a day. So let's go on and have a look at some of the things that are important to us. The first question we might ask is, what is this autonomic dysreflexia? Great question. And as the name suggests, it's a condition that's a dysregulation of the autonomic nervous system. Sometimes it's called autonomic hyperreflexia, and in some ways this reflects the reality a little better. But in a nutshell, we can describe it as an exaggerated and unopposed response by the sympathetic division of the autonomic nervous system directly below the level of the spinal cord injury. The current theory is about 1 month following a spinal cord injury, changes start occurring to the sympathetic ganglion that are distal to the spinal cord injury. Now, these ganglia are the ones that run parallel to the spinal column, and under normal circumstances, incoming nerve impulses from the visceral or cutaneous receptors would result in an autonomic reflex arc that initiates efferent or outgoing nerve messages that would result in vasoconstriction. So in the presence of an established spinal cord injury and this propensity towards autonomic dysreflexia, two things can happen. Firstly, the post-injury changes to the distal ganglion beside the spinal column result in an exaggerated response to any stimulation coming into them. The result is an amplified reaction. The degree of vasoconstriction is abnormally heightened, and this causes a sudden spike in the blood pressure. Secondly, the usual feedback mechanism is disabled. Now, you might recall from the A&P classes in Year 1 that the carotid sinus and the renal apparatus would detect an increase in blood pressure. This would result in nerve signals being sent to the vasomotor center of the brain to oppose this vasoconstriction. However, the presence of the spinal cord injury blocks these signals from reaching the brain, or it will prevent any vasomotor messages from reaching the ganglion below the spinal cord injury. This means that for the regions below the spinal cord injury, the exaggerated response is going to be unopposed. And what's most likely to trigger this response? Most of the stimuli arise from urinary tract infections, urinary retention, urosepsis, urinary catheter placement or the manipulation of the catheter. It can result from constipation or renal impaction or infection there as well. The fact that these stimuli all have in common is that they can irritate or distend the hollow organs. Other causes can come from abdominal distension or colic, or even distal cutaneous pain, say from something like a leg fracture, but the overwhelming majority are related to either renal or rectal causes. Okay, so what symptoms do we have associated with this? The principal sign of autonomic dysreflexia is hypertension, and by definition, an increase in the systolic blood pressure of more than 25 millimeters is the demarcation line for diagnosis. Hypertension may be asymptomatic, but arguably, paramedics are much more likely to encounter this sort of situation because the presentation has been symptomatic. In these cases, the increase in blood pressure can result in a hypertensive crisis and thus organ damage if it's uncorrected. So the worst case scenarios include sudden pulmonary edema or other problems that are associated with left ventricular dysfunction. It can cause retinal detachment. It increases the likelihood of intracranial hemorrhage by about 400%, or it can precipitate seizures or death. Simultaneously, the nerve supply above the injury does remain intact. And some of the other symptoms that you might see with autonomic dysreflexia relate to the strong parasympathetic response and the vasodilation that's going to exist above the level of the spinal cord injury. It's often that this produces a headache in the same way that giving GTN will produce a headache. Massive vasodilation of the cerebral blood vessels. It can cause flushing above the level of the spinal cord injury, and this may produce a demarcation line because the person will be pale below it. And it can produce a bradycardia. So that is the parasympathetic stimulation above the spinal cord injury can affect the heart and slow it down. Although from a statistical point of view, you're more likely to see a tachycardia. The other symptoms that can occur with autonomic dysreflexia include visual disturbances, nasal stuffiness, diaphoresis above the level of the spinal cord injury and a dry skin below it. It can promote extreme anxieties or feelings of doom, and it can also promote nausea and vomiting. So, our assessment strategy is going to rely on three main points. Firstly, is identifying patients that are at risk, so those are the ones with spinal cord injury at T6 or higher, and recognition of the stimulus that's most likely to have caused this. Recognition of the initial symptom is really important, and usually a severe headache that's sudden onset is the first clue that we get. And lastly, we're going to use our vital signs survey to make sure we've confirmed there's an elevated blood pressure associated with this particular presentation. The remainder of the assessment strategy is going to include a clear identification of what the stimulus was and monitoring the blood pressure. This is an excellent opportunity to set up the automatic BP interval on the monitoring equipment to make sure that this happens on a regular basis. And finally, we come to management. The primary goal of any management strategy is to remove the triggering stimulus. Now, examples might include being able to empty a full urine collection bag that's connected to a urinary catheter, or at the least being able to unblock the urinary catheter. As I appreciate that this is not going to be always possible, the principal goal still must remain to resolve this, and sometimes we're going to have to do that by transporting the patient to an ED or maybe getting specialist help to the scene. The parallel goal, the thing that has to be running at the same time as trying to reduce the stimulus, is to manage the symptoms by promoting both vasodilation and venous pooling. Now, we can do this by sitting the patient up with their legs dependent. That'll certainly deal to the pooling issue, but appreciating that a lot of the patients that we deal with are going to have complex spinal cord injuries and may not be able to set up easily. The next thing we're going to have to move to instead is just the use of short-acting nitrates to promote the vasodilation. So we can use both GTN or TTS10 patches to achieve this. But where the reversal is short-lived or it's not achieving the targets, we're going to have to seek further assistance. And so it's possible to maybe start a GTN infusion, or maybe the use of drugs like metoprolol or labetalol, because they have both alpha and blocking capabilities, might come in useful. But I will refer you to the CPGs. So in New Zealand, there's a comprehensive and well-constructed protocol for initiating these levels of treatment. So let's recap this whirlwind tour of autonomic dysreflexia. It's likely to occur in any patient with a spinal cord lesion at T6 or higher, and in some patients with MS. It's usually initiated by a painful or noxious stimulus that, although the patient can't feel it, triggers an exaggerated sympathetic response below the level of the spinal cord injury. This produces hypertension. The spinal cord lesion reduces the ability of the central nervous system to oppose its response below the injury. The patient may have a strong parasympathetic response above the injury, resulting in a demarcation line for the symptoms, such as pallor below and flushing above the level of the spinal cord injury. The worst case scenario on presentation is probably going to be a hypertensive crisis that can cause pulmonary edema, retinal damage, or increase the chance of intracerebral bleeding. And remember, our most common triggers are going to be stimulation or irritation of the urinary or rectal areas. The prevalent symptom that we see is normally a headache, and is often due to the vasodilatation of the cerebral arteries. Management of autonomic dysreflexia is to resolve or mitigate the stimulus, and then to use short-acting nitrates to manage the hypertension. Where this is not effective, GTN infusions and longer-acting agents such as metoprolol or labetalol are the next line of defence. I hope this has proved to be useful, and I look forward to seeing you on the block courses when we discuss this and the management of this crisis a little more in depth. Ka kite.